continue with Dr. Purendra BHASIN. He'll be talking on overview of the whole session till now and also the legal issues which are prevalent in our country. And Purendra is practicing in Gwalior and is a prolific refractive and cataract surgeon, and has been our instructor for last 20 years or more, I'm sure.
Not in this course, or in
many
various
many
courses.
many courses
In many
we are doing
courses,
together. Scleral fixation IOLs and the ICLs and normal IOL cases.
Thank you, Dr. Bharti, and for giving me this opportunity. I just wanted to have regarding topography. This is a recent or current ABCD scoring system which comes in the new Pentacam by the Bell and Ambrosio, and this is superior index, and it takes into consideration apart from anterior posterior corneal curvature, and this includes the corneal curvature 3 millimeter in 3 millimeter radius around the thinnest pachy, and that is the good part. Otherwise, this previous one was taking into consideration the around the apex of the cornea, and this is at the 3 millimeter radius from the thinnest cornea. So anterior, posterior, A stands for anterior corneal curvature, B stands for posterior corneal curvature, C stands for the thickness of the cornea, and D is the change in the refraction, because up till now we have now not included refraction, because change in power in last 6 months, 1 year, and that also is important, and more in the form of cylindrical power. If there is any change, so we should suspect that there is a. So these are all early things which has to be included into by suspecting the keratoconus or chances of ectasia. So overview and legal issues. So post-LASIK ectasia is a known risk factor and a rare but serious complication of laser vision correction. There occurs progressive steepening and thinning of the cornea after corneal refractive surgery. It can occur following LASIK, even surface ablation, SMILE procedure, RK, which is obsolete now, or astigmatic keratotomy, which is also an obsolete now. So in any form of corneal based surgery, this can occur. The hypothesis is that the corneal, which has been fairly enough dealt by my previous speaker, because it's an overview. So corneal refractive surgeries disrupt and thereby alter the structural integrity of the cornea. LASIK reduces corneal structural integrity both by reducing the overall available load-bearing tissue, because we are making the cornea thin, and by shifting the load-bearing responsibility to the structurally weaker posterior corneal stroma. So we all know that the posterior corneal stroma, the lamellae are sparsely arranged as compared to the anterior corneal stroma. So that is, we are shifting the load-bearing responsibility to the posterior part of the posterior weaker part of the corneal stroma. It was first reported by Theo Seiler in 1998 in the case of a formafrusty keratoconus. In majority of the cases, it occurs within 1 year of surgery. In one series, it has been reported late as 6 to 11 years after the surgery. I have seen case as early as one month after the surgery. I have seen case in post hyperopic laser correction. So that is there. The importance of residual stromal bed thickness is cannot be undermined, because biomechanical studies have reinforced the importance of residual stromal bed thickness after the LASIK. Both stress strain analysis and cohesive tensile strength analysis indicate that corneal strength is significantly greater in the anterior 40% of the corneal stroma than in the posterior 60%. The corneal flap contributes minimally to the tensile strength of the cornea. That is another important fact which we all have to keep in mind. After we have created the flap, then the tensile strength of this flap cannot be included into the total strength of the cornea. Thus, LASIK reduces corneal structural integrity both by reducing overall available load-bearing tissue and by shifting the load-bearing responsibility to the structurally weaker posterior corneal stroma. When the complication arises, it does not necessarily means that the surgery was contraindicated or that there has been a violation of a standard of care. that the patient was a poor candidate for surgery. Post-LASIK ectasia is typically a result of abnormal corneal morphology or thickness that has been overlooked prior to the surgery. The various risk factors for keratoconus are weak biomechanical properties, abnormal topography, keratoconus, formafrostic keratoconus, pellucid marginal degeneration. Younger patients who may be predisposed to keratoconus or formafrostic keratoconus but have not yet had time to develop them, and we have operated upon them early. So there is low preoperative pachymetry and the degree of myopia is very high, so which we have surgically corrected. So severe biomechanical impact from the surgery occurs on the cornea. The high percentage of altered tissue, this is PTA, which has been said by Dr. Bharti also. The PTA should be more than a percentage tissue altered should be more than or equal to 40%. So it depends on the initial corneal thickness. If the and Dr. Bharti was suggesting that it should not be more, it should be less than 50% of the thickness of the cornea. If the thickness of the cornea is 600, and we should not ablate more than 50%, like we should not ablate more than 300 micron of the cornea in such cases. So we should be that is what including the flap. We should not exclude the flap. That is what because flap is having, after the flap is created, it doesn't have any value. A low residual stromal bed due to excessive laser ablation for high corrections or multiple retreatments. So residual stromal bed of less than or equal to 250 micron or half of pre-operative thickness, that is a red signal. Thick laser flaps, LASIK flap due to the blade is some problem with the blade or our microkeratom. We have created a 160 micron, 200 micron, and we have taken into consideration that flap thickness of 120 micron. This can lead to problems. Corneal thickness, degree of myopia, and residual stromal bed are therefore interrelated. A small treatment zone causing abnormal focal stress distribution. Some machines you can reduce the size of the ablation optic zone. So in such cases, your stress on the cornea will be at focal point, and which is more and which can lead to the development of keratoconus. Severe trauma after surgery like aggressive eye rubbing, this also has to be considered, and all these allergic cases, we should treat them simultaneously. Retreatment or enhancement has been reported as one of the cause for keratoconus, and other sources of blunt corneal trauma can also lead to keratoconus. Most reported cases of ectasia after LASIK had at least one of the risk factors. There have been case reports of ectasia developing in patients even without risk factors after LASIK and surface ablation, or we may not have understood the topography before. That may be the thing. Ectasia can also occur after uncomplicated surgery, even though candidates are appropriately screened. So what is the incidence? In the earlier days, when the screening modalities was not, technology was not that advanced, with the incidence was 1 in 2,500 cases. With the newer screening technologies like Pentacam and all, it has come down to 1 in 4 to 5,000 cases. And now I think we are very, very cautious. So that has reduced, that is even less, I suppose. There is a ectasia scoring system. I think Dr. Bharti has already spoken over this, and I will go further. Coming to the law and malpractice lawsuit against the cases. So LASIK surgery lawsuits are approximately 30% of all ophthalmology malpractice claims in the Western world. And in this particular instance, the patient stated that they were not adequately explained the risks involved, alleged that the doctor should not have proceeded with the procedure because the patient had signs of keratoconus. And a prominent New Jersey laser eye surgeon has agreed to settle a medical malpractice lawsuit for $2 million after performing a corrective vision procedure on a man who should have been ruled out due to a pre-existing eye condition, that is LASIK, that is ectasia. The lawsuit alleged that he was not properly screened before undergoing the eye surgery, as he had a condition known as steep corneas, which led to bulging of the corneas known as corneal ectasia in both eyes. So, another judgment which took place in 2011 and in the amount of $45 million was entered, and on June 10, 2009, Manhattan jury returned a verdict against Dr. Naxarli in Devdas versus Naxarli for his medical negligence in having performed LASIK surgery on a patient who was not a good candidate for surgery because of the condition of the cornea. As a result, the evidence showed that Mr. Devdas developed a visually disabling condition post LASIK ectasia. So, this kind of $45 million lawsuit, I mean, it completely ruins the practice and name and everything of a doctor. So, another case in 2011, Dean D. Angelo filed a statement of claim against Michael Duplessis, MD, and Cataract and Laser Eye Institute of America, PC, in the Healthcare Alternative Dispute Resolution Office for the state of Maryland for the negligent performance of LASIK surgery. And at that point, the patient took a second opinion, whereupon he learned that he had the corneal disease ectasia and was not a suitable candidate for LASIK surgery. So liabilities of doctor arising under statutory regulatory conditions in India are, as per existing laws in India, cases for medical negligence of the doctor can be filed under following enactments at the option of patients. A complaint for the deficiency of surgery services can be filed before the Consumer Forum under the Consumer Protection Act 1986. A civil suit for damages can be filed in civil court, and a complaint under section 304A of the Indian Penal Code in criminal code, as per. But this is after the recent Supreme Court guidelines against the for the recent the problems against the doctors in our country. They have mentioned that a committee has to screen the case beforehand, and the police cannot file a case under Indian Penal Code directly. First, the committee will be assessing whether it is a case to be filed. A complaint to the Medical Council of India or the State Medical Council for deregistration of a doctor on account of negligence can be done as per the statutory the laws in India. Several cases have been reported against ophthalmologists, and decisions have been taken by the National Consumer Dispute Redressal Commission. It is reported that 942 cases of medical negligence were decided by the National Consumer Dispute Redressal Commission from 2002 to 2018. Out of these, 30 were related to ophthalmology. A total of 73% of the alleged cases of medical negligence in ophthalmology were proved. That is a good warning sign for us, and compensation for the cases ranged between 2 lakh to 10 million were awarded. So what I recommend is that there is an informed consent which is suggested by the recommended by the All India Ophthalmic Society, and they have prepared. Dr. Namrata Sharma and the team has prepared. So for each and every disease, and for the LASIK they have prepared it separately, and for SMILE also they have prepared it, for ICL and other things also. And we should take all this and inform the patient beforehand about the pros and cons and the possibilities of anything which can arise in that particular patient. And even though patient give us a written consent, if you are suspecting the chance that there is the cornea is the patient is a poor candidate for the LASIK, you should wait, you should not go ahead. So to summarize, thorough preoperative workup should be done. Strictly follow the guidelines. Explain all pros and cons to the patient. If in doubt, better to wait or do not go for corneal refractive surgery. Take opinion from your experienced colleagues. I just was discussing in this afternoon only that one patient which was suspected having to have a suspected cornea was refused by one center. Another center took it. Patient had developed ectasia. Fortunately, that patient was managed by CXL, and patient didn't go to the court of law, and they were managed, because now we have the system of CXL. Earlier days we were not having this thing, the knowledge of ectasia and the availability of CXL. So early we can detect, and we can manage it. So this is how patients, we should always be always suspect of such kind of conditions in the patient, and we should refuse or wait for 6 months or 1 year before going for the surgery. To conclude, if you know the enemy and know yourself, you need not fear the result of 100 battles. If you know yourself but not the enemy, for every victory gained, you will also suffer a defeat. And if you know neither of the enemy nor yourself, you are not seeing the cornea, and you know you are not aware of that the patient has developed ectasia, you will succumb in every battle. This is the by Sun Tzu, The Art